Like it's been a hard few weeks. Good grief.
Yeah.
You've had a lot going on, it sounds like.
Yeah, I remember in the beginning you were saying, well, you can be in touch with us because if you start to hate life and hate you and hate everything. And I did pretty good for a while, but the past couple of weeks I was like, wow, I want to tell him how much I hate this.
you're gonna call me out on it now.
Yeah.
Well, I don't blame you. Just remember it was the other guy that looks like me. That's who told you to get the chemo. Okay. So
Okay.
be mad at that guy.
Okay.
Yeah.
He's not in the office today, but I'll tell him when I see him, okay?
Okay.
Well, so as we discussed when I saw you previously, we know that because of the genetic things that we know about your cancer, we know that if it's progressed to a setting where we're not talking about giving you chemo after a surgery, but where we actually have to give you chemo for cancer spots that we know are there, we know that the standard chemotherapy sometimes doesn't work well for colon cancer that has the mutations that yours have. Do you remember us talking about that?
I do.
And we have wondered, as we also discussed, because I know you had asked when I saw you last time, well, what about getting immunotherapy instead of chemotherapy? It's a totally fair question, and we've wondered about that, but we just don't have evidence to use it in that setting yet. But given that you're feeling worse, that your pain is increasing, and then the results from the CT scan when you were in the emergency department in the last few weeks, I think there are two things. So the first is that it's always wise when we thought that the cancer had gone away and we suspect that the cancer is back, it's always a good idea to biopsy it just to make sure. Given the circumstances in the clinical picture, I think that that's very, very likely here, but you just never want to get surprised somewhere down the line that, oh gosh, you thought it was, the cancer coming back, and actually it turns out that it was some different kind of cancer or something else going on. And so I think that would be thing number one.
How invasive is getting the biopsy?
It's a good question. Remind me where you guys live.
Lodi?
And that's a number of hours from Stanford, is that right?
Yeah, about 2.
Yeah. So, what we would normally do in this circumstance, and we can do this in this circumstance if you would like, is to refer you. We have doctors here who, it's a little more complicated than this, but in effect, they are sort of biopsy specialists, among other things. And we can refer your case to them, and basically we would ask them to biopsy whatever is most easily and safely biopsyable. My guess is that the way that will work is via what's called a CT guided biopsy, which is just what it sounds like. They have you on a table like you were getting a CT scan, but they use a real-time CT scan. So the CT scan is happening while they use the CT scan to guide a needle going in, take the biopsy, and then that's the way that they do it.
Yeah, I just had one.
So there you go. So that makes it so you don't have, it's not considered a true surgery. I mean, it's kind of like a surgery, but it's not a true surgery. It's an outpatient procedure. It's generally very safe and well tolerated.
Yep.
And that's probably the quickest way to do it. You may be able to do that there in Lodi as well. I don't know. I know our folks and know that they do a good job and know I can trust them. So we're happy to refer you here, but we're also happy to coordinate for you to get it done there close if that would be better for you.
Okay. The other thing, of course, is that we were hoping that you would have the scans for you to be able to see them yourself instead of reading a report. But hopefully they're on their way.
Yeah, you would think that Stanford being in the heart of Silicon Valley, that we could just snap our fingers and have the scans appear on a computer screen. Yeah. But for reasons I still don't totally understand, it just doesn't work that way.
Yeah.
But yes, we will. But the truth is, even if I had the scans here in front of me, I mean, I can usually look at them and kind of say, well, looks like this might be a good spot. But we always have to have the interventional radiologists review them anyway, because there are often considerations that I don't take into account about, because it's not just whether the place can be biopsied, but what's the path of the needle going in, and what are the other things that are around it. And anyway, which, they know better than I do. But talked about this to some degree with Dr. Shaw, but I think that what I would do is I think it would be good to work on two tracks at the same time. So on the one hand, I would be getting the biopsy, and then on the other hand, I'd be petitioning the insurance company to get approval for the immunotherapy drugs. As I think Dr. Shaw discussed with you, there are two main things that I think are important to discuss about the immunotherapy drugs in this context. Well, three main things. The first thing is that there was just a big study that was first presented to us about 9 months ago now, and has since been published, which basically asks the question, not for post-operative therapy, but for somebody who has cancer that's come back, who has the kind of mutation that your cancer has, is it better to start with old-fashioned chemotherapy, or is it better to start with immunotherapy? And that study shows that it's better to start with immunotherapy. So I know you're going to think that other Dr. Johnson was telling you lies that you talked with before. I'll be sure to report him to the medical board or something. Yeah. Okay. I know it seems a little strange that we still do old-fashioned chemotherapy in the post-operative setting, but do this in this setting, but that's just where the data is right now. But anyway, so that's number one, is that it does seem to work better. Number two, there are lots of things we can worry about with immunotherapy, but the two that are the most important in this case are the following. One is that there is a concern that sometimes if you have cancer that is growing quickly, there is sometimes a concern that immunotherapy may not work as well as old-fashioned chemotherapy at slowing down rapidly growing disease. Having said that, though, from the looks of it, it seems that your cancer has grown in spite of the chemotherapy, the post-operative chemotherapy that you've already been getting. And what I think that probably tells us, which frankly is not that surprising to me given everything that we know about your cancer, but what it probably tells us is that your cancer wouldn't respond to old-fashioned chemotherapy anyway, even if we gave it to you. Now, there are medicines, old-fashioned chemotherapy medicines you haven't had yet, and it's possible that those could work. But on balance, I think that we have a better shot of it working with the immunotherapy than with the old-fashioned chemotherapy. That's number one. Number two, you carry this diagnosis of rheumatoid arthritis. And I know that that's not, from what I understand from Dr. Shaw, it doesn't sound like that's been actively causing you a lot of problems here recently. But nonetheless, I just need to let you know, so that, the way that immunotherapy works in effect, for many years we thought to ourselves, well, gosh, why doesn't, if the immune system that attacks an infection, if you get an infection, why doesn't that same immune system recognize the cancer as a foreign invader and attack the cancer? We've known for some time that it does attack the cancer to some degree, but it often didn't seem to be very effective in its attack, and we wondered why that was the case. So about 10 years ago, decades of research from before that led to the manufacture of a new class of drugs called immunotherapy drugs. And basically what we had discovered is that one way that cancer evades the immune system is to in effect produce a stop sign, so that when the immune system comes to attack the cancer holds up the stop sign and says, oh, I have nothing to worry about, leave me alone. And then the immune system says, oh, looks like this is fine, and then goes somewhere else. So there's a new class of drugs, not that new anymore, but relatively new, that effectively take down the stop sign. So now when the immune system comes up to the cancer, it says, oh, this is bad, this is a foreign invader, and then starts to attack it. The other side of that coin, though, is that by taking down that stop sign, you also empower the immune system, in some cases, to attack the body's healthy cells. So that the immune system says, oh, look, a healthy lung cell or liver cell or heart cell or whatever, I'm going to go attack that as if it were a bacteria or what have you. And so, in effect, one possible side effect of immune therapy is that an immune therapy drug can make it so that your body has an autoimmune side effect that affects virtually any organ. So it can affect the liver, it can affect the lungs, it can affect the heart, whatever. And in a person who has a history of something like rheumatoid arthritis, which is an autoimmune disease, you can have the situation where whatever that rheumatoid arthritis looked like when it was first diagnosed, that can re-flare in the context of getting the immunotherapy. So you can end up in a place where that same disease comes back. Now, have you in recent years followed with a rheumatologist?
Yes, I have. At one time, I was on prednisone and what's the other one? Quite a few of them.
How long would you say it's been since you were on prednisone?
It's probably been a couple of years now.
And when you were your very sickest from rheumatoid arthritis, how sick were you?
Well, it was more the exhaustion and fatigue than it was swollen joints or anything.
Yeah.
But I think even then I would have pains in my back and everything. I think I've had pains before where I've had to
joint pain.
Yeah.
Inflammation.
Well, so here's what I would recommend. Again, I recognize that this adds a little bit to your plate, but I think it's worth it in the end. We're going to refer you again to a rheumatologist here at Stanford. I think it's particularly important that you be followed closely by a rheumatologist, and I would prefer it be one that I can reach out to directly and talk to easily.
Yes.
If we're going to be putting you on immunotherapy, for two reasons. One is because it'll be helpful to have their input in terms of helping you to understand sort of what the risks of the immunotherapy look like and what it could look like if your RA flares up again and all of that. And then two, because that way, if we do get into trouble, especially if you were diagnosed, it sounds like yours is a little bit tricky in the sense that you didn't have some of the super classic things, as you mentioned, the swollen joints and whatever, but it sounds like they were convinced enough about the symptoms that they put you on steroids. The reason that I mentioned that is that we can often face the scenario for someone, especially who has a history of an autoimmune disease who we're now going to put on immunotherapy. We can often end up in a place where we're saying, well, gosh, now they develop a symptom while they're on immunotherapy, and we have to say to ourselves, well, gosh, is this related to the immunotherapy? Is this related to the underlying cancer? Is this something that we should give them steroids for? Should we stop the immunotherapy? Should we keep going? That can be a little bit complicated, and so I think having them on board would be helpful. So all of that, let me now summarize all of that stuff together. What I would recommend we do is the following. I'd recommend that we get the biopsy, and we're happy to facilitate that here if you would like, although if you'd rather facilitate it there through Dr. Mehdi's office, that's also fine.
Can we do that at the same time as seeing the rheumatologist?
Well, so that's what I was going to say, is that I would recommend that we set up, if you're going to do the biopsy here, we can try to set those things both up. We can try to coordinate the visits. It may be that the rheumatology visit can actually be a video visit anyway, so you don't have to be in person. I'm not sure what their policy is. I'm going to have to talk to them about that. But I'd recommend that we set both of those things up. In the meantime, I would recommend that Dr. Mehdi get the insurance approval for the immunotherapy, so that the idea will be that basically as soon as we have the biopsy results back and you've seen the rheumatologist, then we go ahead and get you started on the immunotherapy and then go from there.
Okay. And that's something Dr. Mehdi starts that process on the approval for the immunotherapy.
Yep, that's right. And the immunotherapy drug is going to be exactly the same whether you get it here or there. So that piece, there's really no reason. I mean, you could get it at Stanford if you wanted, but there's no reason to come to Stanford for the medicine.
Yeah.
But the rheumatologist, it's just that if you were to see one locally, then if I'm trying to get in touch with them, it's much harder to get in touch with a doctor from a different network than you might think. And so it's just better if they're here at Stanford.
Yep. Agreed. Okay.
So those are my thoughts. So why don't we do this? We will make all of those referrals. You should get a call for the rheumatology visit and a call to either have a visit with the interventional radiologist or just to get set up for the biopsy. It depends on how they want to run that, but you should get a call for those in the next few days. If you haven't gotten a call from both to set up both of those things, the rheumatology visit and the biopsy or the biopsy related visit, if you haven't gotten a call about those, those by this time next week, please send us a My Health message so that we can call the appropriate people to get that ball rolling. And then we'll plan to see you back in 2 weeks, with our hope being that by that time you've seen both the rheumatologist and the and at least had the, hopefully are either in process or hopefully have actually had the biopsy done. And then I think I have a text message actually from Dr. Mehdi, I want to say. In any case, we'll get in touch with him to let him know to start working on the getting the insurance approval for the immunotherapy.
Okay. That sounds like a good plan.
And in the meantime, if I see that other oncologist who works here, I'll be sure to give him a piece of your mind on your mind.
Okay.
All right. We'll see you guys in a couple weeks.
Okay.
Thank
Thank
you.
you so much.